And the first thing I want to do is point out that this is a very informal title, Tips for a Good Initial Interview Regarding SUDs, Substance Use Disorders, or more importantly, regarding people with substance use disorders, and some pointers about comorbidity. So tips and pointers don't sound like, are supposed to sound like this is not the most evidence-based talk. This is clinical experience-based. And so everybody's experience, and notice I didn't say clinical wisdom because I don't think I've gotten to that. But, you know, whether I get to wisdom before retirement is now neck and neck. So we'll start there. So the goals of the initial assessment. You know, when I wrote that up there, I actually took this slide from a talk given at the AAAP in their education course, preparing for boards. And I realized that really the fourth bullet, assess, understand, and enhance patients' motivation to change, maybe should be the top bullet and is by far the most important bullet. In fact, sometimes my problem is that we have templates for all those other things in boxes and things to fill out. And I spend too much time filling things out and not enough time staying with the patient and where they are. I mean, like this last case, motivation was the whole thing. Nothing else really mattered without motivation, and really nothing else matters from day one in addictions without motivation. So I wanted to pop that forward a bit and remind people about that. But the other thing that happens a lot, especially with us addiction psychiatrists, is to relate the substance-related disorders to potential comorbid medical and psych conditions. And that almost always is complicated. And we sometimes never get back to it with the, what would I say, the tenacity which it deserves. You know, who has known this person when they were actually sober for some chunk of time? Who has known them when before they started using? What were they like? What are they like now, even during short terms of sobriety? And we really get so into the rhythm of our day and the rhythm of the patient's day that we sometimes don't press hard enough to get back to that core issue. The other thing I think we often I don't do well enough is get all the, identify all the barriers, even the mundane ones that turn out to be remarkably important. You know, you have a car and you can use the car every day and you still have a license and you have gas money, and how many days a week do you think that car will actually start? I never ask quite enough questions about day-to-day life. And what hours of the day could you actually come to treatment when you don't have childcare responsibility or work or whatever? And pretty soon I find out, well, everything sounded good when I asked global questions. When I asked specific questions about barriers and strengths, the barriers sounded a whole lot harder than I ever guessed. And if you start down that road where people said, oh yeah, I can come, and you didn't specify, then pretty soon your team is like mad at the patient for not showing up, where had you actually asked about all the barriers they faced, you would have been more like, wow, you got here. You know, it's like, that's incredible. I don't know how you made it. Let's see, I got control here. So interviewing styles are really important. And every single thing you ever read in medicine talks about open-ended questions. And open-ended questions are really great if they work. And unfortunately, because again, you have X amount of time, and you can't use open-ended questions forever with most people because some people give you too little and some give you way too much. And so you really do have to jump in with what I put on secondary, second point, which is to come up with honest, respectful, empathic, matter-of-fact questions. Like Columbo, the old TV detective. And he would always be like walking around saying, you know, there's just the one thing I don't get. Can you help me with? Understanding, and of course, for him it was understanding the murder. For us, it's can you help me understand how this works? How do you take heroin 3 times a day and get to work and take care of your children? And tell me more, a little bit more. Let me understand that. And I always come out when I do that well with some both remarkable respect for, again, how people get through their lives, and also real worry about how can this change. Being honest about why you're there is incredibly important. Many people, we often forget, thinking that we are obviously trustworthy, helpful people who are only there for the patient's good. They may have a very different view of us for gender reasons, culture reasons, ethnic group reasons, interactions with other professionals, legal world, etc. It's very, very important to be very clear about why you're there and if you can come to some kind of common goal. Sometimes the patient comes up with goals that don't include me or the team. And I always am excited about that. I said, I don't actually care how you get better. I just hope things start from kind of around now and start heading towards better. Better is good. I mean, I'd love it if it was perfect, but I haven't had a perfect day yet. So, I'm still, we're hoping for one. But better, we can go for better. And sometimes it's often possible to head towards better.
Yeah, Dean, on that respect thing, it was interesting. Elise and I yesterday watched the live stream of the congressional hearing on a big bill for addiction care. And they talked about relapse and people getting multiple treatments. And the psychologist there, who was actually the CEO of the American Psychological Association, talked about a case where a person had multiple treatments, and they said, what do you think made this last treatment work, whereas the other ones didn't? I said, well, it's because the therapist called me sir. I had never had that happen before. And if I was going to be in a place where I felt respected, maybe I was going to really do something. It's as simple as that.
Cool. So, how do patient characteristics affect it? And actually, I should put in how do interviewer and provider characteristics affect it, because age is a factor of whether you're younger or older than the patient. Years ago, when I called people sir and they were 20 years older, it felt right. A lot of the people who are 23 and I call them sir find it a little weird, actually. But that's just the way I've been doing it for forever. And so age, I always say, don't try to be, it's hard to be younger than you are, which tends to be the more hardly, I guess when I was really young, I tried to be older than I was, sort of. But remember, gender does matter. The rate of abuse in women with addiction is, remarkably high. So if you're a male, it's usually done by a male. So if you're a male interviewing a female addiction patient, you know, you need to be respectful about what's going on, and you may not find out about that for a while, and you wonder why things are going on. Well, it should be obvious after a few years of this, but it sometimes surprises people over and over again. Partner and marital status, and the case was perfect about that. People are, women especially, are much more likely to use in the pattern their partner is using, and have a very, now I often wonder whether those kinds of data need to be repeated every 10 years as culture changes. I don't know, but certainly she kind of went with the use pattern of every partner. So that's a huge barrier. Legal status, I'm going to skip over some of my little notes to myself about probation patients, etc. Employment status, you know, people are all excited about insurance until they understand that the person has to keep going to work to keep the insurance coming, and that gets in the way. And so it's good, bad. On the other hand, going to work limits the amount of time you have to use. So it can be a strength, it can be a barrier, it can be all of the above. And then if you happen to work as a bartender or an anesthesiologist, it can be a huge problem. So,
and I've seen with some counselors that we will call old school, that they will say, you know, you have to put your sobriety first. Right? There's nothing else you can possibly do. And if you put your job ahead of your sobriety, you'll lose your job, and then you'll lose both. And there's some wisdom in that if you don't get well, you're not going to be able to be functional and keep that job. But I've also seen them be really insensitive and unrealistic at times in making the statement. You have to put your sobriety first. And if you're choosing your job, you actually don't have your heart in this, and can get very judgmental. And so,
and if you're 2 weeks from a cardboard box on the street, you know, the job has to.
Yeah. So we have to deal with the reality of people's lives, and when we did an analysis of AMAs from inpatient detox many years ago, I would say that the number one thing that we could find was an association with AMA. It had nothing to do with what people might think it had to do with. The number one variable is, I just got a phone call and my childcare fell apart, and I got to go home and take care of my child. Mm-hmm. And that's it. And I don't care what else you say, I have to take care of my child because the childcare fell apart.
Yeah.
And that's the number one reason people would leave the patient. And you just have to be aware of reality.
Yep. Psychological and medical issues affecting the interview. Level of insight, my all-time favorite. You know, the word denial comes in and out in addiction, but my all-time favorite guy was a guy who came in, he actually was on his 14th DUI across 20 years, across about 6 states. I think he had DUIs in at the time. And he says, "You can't believe how unlucky I am. I get caught." So we figured out that he'd actually been drunk driving at least twice a day, every day for 20 years. So it's 730 times 20 is, you know, what, 14,600. So he'd only been caught 14 times. So I said, you're actually about one, they figure you get about 1 out of 1,000 get caught. So you're actually a little luckier than average. But you can actually get lost in this because sometimes the denial is so massive that you start arguing. And I've never argued anybody on the first session out of it. I think you note it and you keep going and realize you're going to need to get corroborative history somewhere else. When somebody can come in and tell you they're on their 14th DUI, you know, they're probably going to shape the facts on other things as well. A personal explanation is always an interesting one. Anybody with my pain and PTSD would drink, would use, would whatever. And of course, you can argue that because actually that most people with pain and most people with PTSD actually don't do that, although it's a big chunk of them. But you're not going to just argue, don't stop and argue on the way in. That is an important thing you're going to have to address as you go through things. Psych and med comorbidities, bipolar, social anxiety, pain, all have clear stories connecting them to the problems. But again, finding that point in time where they've had some sobriety for a significant chunk of time is really important. A psychological and medical issue affecting the interview is always, where were you in your addiction or recovery story when you relapsed and when you came back in? And the classic one of horrendous situations are when you see somebody who's in recovery and actively in the world of helping others with addictions. And the relapse of a person in that takes the abstinence violation effect and multiplies it like 500 times. And the shame and the guilt is so great that it's really hard sometimes to get an actual history. I mean, it just kind of breaks down in shame, really. And sometimes I think, I can't take any more of this history right now on the first time because I'm inflicting too much pain. They're never coming back if I just keep poking. I know what the story, I know enough of the story to treat. I don't have to do it all today. And that's maybe an important part because you have to have them motivated to come back. It's the most important thing is not getting every fact. The most important thing is the second time. See the current state, of course, is an interesting one. Now, I think sometimes we actually don't quite value the intoxicated statements enough. Everybody waits until people are sober. I had a guy yesterday who's just drank between 10 and 30 drinks every day for the last 18 months. And he's quit he quit a week ago. He started taking his lithium again 3 days ago. But during that time, he was suicidal. And he's had other streaks like that. And we always and he says, I don't feel suicidal at all now. And I said, but most of the time you're drunk. You know, I mean, I guess we both need to worry about it. He says, I really don't want to kill myself. I said, well, that might be a good reason to put on the list of why not to drink. But it's interesting how we take the current state. So, and the other problem is we often take the history while people are semi-intoxicated or certainly in withdrawal, and maybe they've just had a couple of benzodiazepines for their withdrawal. And we take that history and put it into the first history format as though it's true. And it's certainly taken under some unusual conditions. So.
But on the other hand.
Yeah, go ahead.
It's also a free Amazon interview.
Yes.
So taking it with a grain of salt one way or the other.
Right, exactly.
And so what I found is you can't do collaborative planning with a drunk person. You can't negotiate with the drunk person what they're going to be willing to do or not do because they're just not in a state to sign a contract with you. So I don't do treatment planning with the drunk person. But I will sometimes ask questions of a drunk person because the stuff they wouldn't tell you because of their shame, maybe they'll tell you because they're so disinhibited. Mm-hmm. And so it is a preamble. It is a preamble interview. So the one thing I liked, one of the many things as I was thumbing through your handout, was you said at one point, this is tips on the initial interview. How is this different from any other interview? is this the same tip for a later interview? And the deal is that the world we're in now with an electronic health record assumes a competent patient and accurate data the first time, and it's put in the record, and it's like permanent there. And what we say is, because it's there, you don't have to re-ask the question, and it's, it's respectful of the patient's time to not asking the same question 5 times. Well, with addiction, asking the same question 5 times is often exactly what you need to do, because the story reveals itself over time as the person's shame changes, as their motivational state changes, as their insight changes. And so the first set of data you get, whether they're drunk or sober, that's one point in time, one set of facts for that point in time, and it may not hold up.
So obviously we're not going to get very far through all these slides, but the next one is important: what needs to be treated. And just now I had a call on the way over here on the hotline, and really the person was in a treatment setting, but it wasn't clear to me that they weren't still in withdrawal. And it also wasn't clear to me that they could have actually gotten intoxicated in the setting again. And so sometimes we think that, well, we're now doing treatment, and we forget that we might sometimes need to go back and assess, maybe this person's intoxicated and they're having problems in treatment today because they're intoxicated again, or maybe they're still experiencing withdrawal from the benzodiazepines they've been on for years before coming into treatment. You certainly see that last longer than the drug half-life would make you think it should. So, getting a longitudinal history. I like using the calendar approach, figuring out what they remember. Veterans, I often use 4th of July, Memorial Day, Veterans Day. Other people, it'll be Christmas. Some people will be the Super Bowl. It varies. Life stages, remember to ask about what was it like when you were in high school? When did you first get married? How old were you then? Or when were you in college? Or, you can get stages that actually help you get some linearity or longitudinality to the story. And then maybe you can relate onset of psych med issues and onset of substance use and substance overuse over time. So this kind of speaks for itself. But remember, comorbidity is actually the rule. But we resist it and patients resist it. We would like everybody to be pure, right? Can't you just be a plain bipolar? There aren't any. If you're bipolar enough, you have gotten into other problems. If
Dean, given that this is echo and the variety of people watching in, and I know that the slide you jumped over goes without saying, it speaks for itself.
Okay.
I found that it happened even this year with a very fine primary care doctor who wants to spend more time on addiction. Was with me doing an interview, and she was fascinated by this.
Okay.
Never been exposed to the concept. Didn't realize this was a way that you could do it, and said, I'm going to adopt that.
Okay.
And so it's not known to everyone, and it does go without saying, it's so good that we just take it as the most standard thing in the world. This is how you grab the golf club, the hands this way. That's obvious. Well, it's not necessary. So this is really, I find, the best way to get to that.
The story of first-time use actually is often useful. I always like the people I know had severe early onset alcoholism are the folks where, when did you have your first drink? Well, my dad took me and sat me down, and we sat down with a fifth of vodka. He says, it's about time you learn to drink. This is the ultimate nature-nurture problem. the guy who gave you the genes also gets out the vodka when you're 12, and you successfully drink your half of it because you've clearly gotten the genes that are involved with sort of inborn tolerance, because anybody else, any other 12-year-old would have died on the spot. And so then you're sitting with that person 25 years later and you think, I bet this person could have developed quite a problem by now, because age of onset of heavy drinking is the #1 predictor of severity of drinking. So thanks, Mike. So comorbidity is the rule, but we resist it. I drink or I use, I'm not crazy. I'm bipolar or depressed or anxious, I'm not an addict. Sometimes this all adds up to, I can't have more diagnoses than I already have. I refuse to have any more. If you give me one more, I got to take away one somewhere. I've had that talk lately with a person. I have to take drugs for my mood. What else can I do? Yesterday, there's lots of talk about Michael Pollan's book about hallucinogens and effects. Well, I had a patient come in yesterday. He says, well, you know, I'm going to switch over to hallucinogens. It's a bipolar alcoholic who I mentioned earlier, who had done a fair amount of research on that. But I thought, well, it's kind of an interesting thing. It's a point in time where maybe people will be doing that soon, taking substances that we used to call drugs, not medicines, for their mood or for their addiction. And then, you know, depression is an excuse, not a disorder, which is certainly an old statement that comes up still. And then again, the patient I got the hotline call on today, the #1 thing they needed was corroborative history. It was just impossible to discern the characteristics of a bipolar disorder versus 2 different kinds of intoxication and withdrawal. So I think we should probably stop here, given the time, and we'll get back to the actual numbers on comorbidity at some other point.